Hello, and welcome to the ImpediMed Academy webinar series hosted by ImpediMed. My name is Joanne Yao, and I am the Senior Director of Marketing with ImpediMed. Today's webinar is titled SOZO Digital Health Platform, Understanding Body Composition Outputs and Case Study Review. We have two very experienced panelists joining us today, Maree O'Connor, physiotherapist at the Victorian Lymphoedema practice in Australia, and founder of Lymphoedema Education Solutions, and Adam Brown, a key accounts executive with ImpediMed. This webinar will be a live presentation and case study review within the MySOZO software. We encourage you to participate by submitting questions via the Q&A icon on your screen at any time during today's discussion. We will answer as many questions as possible during the next hour, and we'll follow up on any questions we are not able to address live. We're also happy to offer certificates of completion for your participation in this webinar upon request. To request a certificate, you may either respond to your registration confirmation email us at info@impedimed.com, or contact your ImpediMed representative. All of our webinars are available for replay approximately 1 week following the event. You may find them on ImpediMed's Oncology YouTube channel, and make sure to subscribe while you're there. So now I would like to ask Maree and Adam to come on video and off of mute to start the presentation. Welcome, Maree. Welcome, Adam. Thank you for joining us today. We're looking forward to a great webinar. I'd like to go ahead and start with introductions. So Maree, would you please introduce yourself and tell us a little bit about your practice?
So as you mentioned, I'm a physiotherapist and a lymphedema practitioner, and I started in the world of lymphedema back in 1991. So I have seen a lot of change, and I've seen a lot of change with bioimpedance as well. So our practice is a private practice in Surrey Hills in Melbourne in Australia, and we see the full spectrum of clients. So we see primary and secondary and all levels of severity. So from early intervention right through to very severe lymphoedemas. And my other area of passion is education. So I'm very fortunate to be able to educate health professionals here in Australia from a variety of programs, depending on their needs, to assist them with their lymphedema clients.
Thank you, Maree. It's great to have you here. We really appreciate you being on this webinar today. And Adam, would you please tell us a little bit about your background and your experience?
Yeah, absolutely. Thanks, Joanne, and appreciate everyone getting on today. And I'm so excited to have Maree on board as well. So my name's Adam Brown. I've been with ImpediMed for nearly 6 years now, key account manager in the US at the moment, and then also looking out the European distribution and also the Australian distribution as well. So I know there are some Australians on the call, so many of you may not have known that I've actually moved to Dallas in Texas. So howdy y'all, I'm learning those sayings. But yeah, really great to be here. This is my passion area. I love the body composition side and what it does really for patients. So it's going to be great to hear from Maree about how she's used a lot of the outputs with our technology, and we can educate everyone on the webinar. So please feel free to answer those, reach out, put some questions down for Joanne, and we'll get to all those as well. So thank you.
Yeah, thanks, Adam. That's great. And let's go ahead and get started. So we're going to get started by reviewing the body composition analysis and reference ranges. So Adam, would you please reorient us to that information and how SOZO, the information that SOZO provides and how you approach your education to it as well.
Yeah, absolutely. So I'll just do a brief summary of the body composition analysis side with SOZO. So the slide you're seeing at the moment really kind of highlights the 3 key areas that we can look at with body composition. So fluid, tissue analysis, and also metabolic. More than weight, it gives us a lot of information. So if you don't have access to this type of information, the only 2 things really that are available to us to look at change are weight on the scales and potentially something like BMI. So body composition really empowers you as a healthcare professional to look at more information. The three elements there, fluid, tissue, and metabolic, I kind of say to a lot of patients, hey, I'm trying to find out how much fluid you have and also where that fluid is, how much muscle you have, and also, if we need to have that conversation, how much body fat as well. The thing to remember is all of those work hand in hand. So you can see there's a lot of information on the SOZO, but ultimately that's a really quick and easy way to kind of figure out exactly what's going on. The other thing I want to mention is that the data is validated. So, we are validated against the gold standard dilution technique, and we do correlate well with DEXA as well. But that gold standard, dilution technique is a great thing. So you know that the information that you're providing your patients has the accuracy and the reproducibility, the reliability that we need to be able to make some decisions as healthcare professionals. And that leads me to the third point. It really is important to find out exactly what results we're looking for and are they actionable? What's the clinical relevance to the patient and how do I deliver that message? And we'll go into this in a lot more detail. And I'm super excited about Maree sharing her case study because it's a fantastic example of how the results can really impact the patient. So if we delve a little bit deeper into the fluid side, you notice that there's a range of parameters. So total body water, extracellular fluid, intracellular fluid, and HIDEX. And they're all important. But I wanted to highlight a couple of things because we'll go into some more detail later. There's a couple of ways to look at this information. So, there's liters and there's also pints and there's also percentage of weight. So anytime we talk percentages, it starts to bring in the reference ranges that we have the capability now with SOZO version 4. But the reason I'd also love to talk liters because it's very tangible, and we'll see that in the case study coming up. But it's a great way to have a conversation with the patient. And I know for myself, moving from an Australian winter, which I'm not missing, to a Texas summer, I think my total body water was down something like 3.5 liters. So that gives me a really good idea of what I need to do to improve my fluid status. So that becomes critical when we look at the fluid side. If we move on to the tissue analysis perspective, again, there's some really key numbers that we need to look at. So skeletal muscle mass, again, kilos, pounds, and percentage of weight is the way that's recognized. There's also fat mass, fat-free mass, and protein and mineral. And we'll go through some of these. Ultimately, the fat mass number, I think and also the skeletal muscle mass side are the two key parameters that we really want to look at. And often when I'm looking at skeletal muscle mass, again, how do I deliver the message to the patient so they get the change in their habits or they're compliant to my programs? I like to say, hey, if you've got 25 kilos of skeletal muscle mass as you're going through your treatment and through your rehabilitation programs, we want to try and maintain as much of that as we can. If I've got, say, 25 kilos or roughly 50 pounds, how do I build another 1 or 2 pounds or 1 or 2 kilos? And that can be really powerful. So that's really important. How do I deliver that message? Percentage of weight is really useful when we start to try and figure out where that patient is on the reference range or the healthy range. So if we move to the next slide, you'll see that we've introduced on version 4.0 some body composition reference ranges. They're available for all of the key outputs. You can see on the left-hand side here, but there are different forms of the reference ranges, and that depends on where we've gathered our information from. If you look at that middle fat mass example, you can see it's a colored screen, starting from very lean right through to a very high body fat percentage. You can see that the actual result comes up 30.8, and that relates to the percentage of weight this person has on their fat mass compared to their overall weight. And you can see a little black line there, which is our baseline. So we can set our baseline, and then the big black dot is the actual measurement on that particular day. That, for example, comes from the American College of Sports Medicine. So that's a big data set, lots of age, characteristics, whether they're male, female, lots of ethnicities. So when we look at these reference ranges, they link to whether you're a male or a female. Some of these will certainly use BMI in terms of the research that used to derive that calculation, but they're in blocks of 10 years. So, if you're a 30 to 40 year old, 40 to 50, etc., that range will really relate to you and your, the specifics around that. So it becomes very nice as a clinician to be able to use that information. The other way we look at the information is being shown here on the skeletal muscle mass side. So this is a standard deviation. So again, we have the same principle. So we have obviously the little dot, which is our result. This obviously is the baseline, and the result 28.2, which relates to percentage of weight as well. So what does it mean? Particularly how to use a standard deviation reference range. So if you look at the next slide, it's useful to understand how we're deriving that, because it becomes powerful for you to use that for your patient moving forward. So the example here, we have a reading of 50.6. Now this may well be, a skeletal muscle mass number or something else that uses a reference range. It's worthy of noting that our total body water, intracellular fluid, extracellular fluid ratios also use this standard deviation perspective. That data comes from some of our internal ImpediMed data, but ultimately it's coming down to the mean. So the mean is what is the average of the healthy population for that data set. We know that with standard deviations out to 3, so -3 standard deviations to +3 standard deviations, that covers the majority of the population. So 99.7% of the population will sit in there. We know when we go to 2 standard deviations, so this lighter sort of grey area, that's covering about 95% of the population. And when we're in 1 standard deviation territory, like this example, it ranges from about 68% of the population. So you might say, Adam, what does all that mean? And there's 2 key factors that we're looking for. First and foremost, with body composition, is trend over time. That's really important when we're looking at that information. Is the data trending in the right direction? And the other thing to consider when you're looking at a standard deviation is how far away is my patient from the mean of the population. So in this example, they're right within that -1 to +1 standard deviation, but you might have someone that is an outlier, sits around -3 standard deviations. So an improvement for that particular patient may be going from -3 to -2, and that's the trend that we're looking for. So I hope that helps in terms of understanding the reference ranges that we've used. By all means, there's some questions, after we can answer those as well.
Adam,
Definitely.
if you don't mind, I'll chime in. There's a great question that just came through. And the question is, can we get a copy of the slides? So I'm going to answer that. What I would like to point out is that there's a couple different ways to get access to this information. First, you can look out for the webinar replay, which will be available within a week. Second, you can contact your local ImpediMed representative who can get this information to you. Third, you can go to ImpediMed.com, and under the resources and support menu, we have a knowledge center. If you go to the body composition analysis section, you will see body composition analysis reference ranges. There's a really nice downloadable PDF that has all of the information that Adam just reviewed available. You can download it, you can save it, you can print it, all available at ImpediMed.com under resources and support in the Knowledge Center. So thank you for the question, and don't hesitate to ask more. We did get the question, Adam, whether the reference ranges are ethnicity specific.
Yeah, so depending on what we've derived our information from, I know certainly the ACSM guidelines will have that component. Some of the others won't as well. So that's where I think ultimately knowing, where your patient sits is really important. And I'll explain that on the next slide, actually. So if you want to move forward, one of the big features you can have with the SOZO version 4.0 is history. So, my starting point becomes really critical. I can set a baseline, for all of the different parameters. So you can see this little black line running across the screen is baseline. So ultimately, the reference range can be very useful, certainly for a healthcare professional to maybe even put that information into the hands of another healthcare professional. But ultimately for the patient, they want to see the trend and trending in the right direction depending on the parameter. So the advantage of now SOZO version 4 is it's very quick and easy to look at some of these results. Again, we have the ability to look at liters and also percentage. This one's total body water. It could be skeletal muscle mass as well. I always say with body composition, trend is critical. So if I have one measurement, that gives me a little bit of information, about myself, about one of my patients. But until I get a second measurement and then a third, when I've got a third, I've got a trend over time. And that's when I can start to really make some clinical judgments about what is happening. So hopefully that kind of gives you a bit of a summary of all of the body comp information that we're going to go through. I just wanted to finish on a little case study from someone in Australia, actually, you know, a patient that has had a SOZO reading, you know, for many years, and it really impacted him. So you can see this patient is a post-cancer patient, you know, had lots of things happening. So compression fractures in the thoracic lumbar spine region, low testosterone, osteoporosis. So there's a lot of things happening with this particular patient post-cancer. The interesting thing with this and working with his exercise physiologist was he was very scared to even start an exercise program. I know he'd had some conversations with his physicians, and because of all of the secondary issues that had occurred, he was very reluctant to get on board with, you know, what the exercise physiologist was telling him. So the SOZO was used as part of an education process and a confidence building idea for this patient to really say, hey, you can actually do more than potentially you think yourself, and potentially even the physicians as well. So I said before, we look at all of the information. So we look at fluid, we need to look at the skeletal muscle mass, and we look at fat mass. But I just wanted to highlight the impact that actually one measurement can have on the patient, because ultimately that's what I'm about, you know. So we look here, we've got 2 or 3 measurements on this little case study. There's a significant decrease in their skeletal muscle mass percentage, as you know, we're trying to educate and teach this patient that they can actually do some, you know, regular exercise and some resistance-based training. But what's important is the second last reading to the last reading, there's actually a positive change, and I've highlighted that in green. Now, when I look at that data, it's only a small change, but it's a significant change, and it had a huge impact on what this patient could perceive themselves doing from an exercise perspective. And I have a little quote just to finish my slide deck from this particular patient. And he says, I feel fitter and stronger now than I did pre-cancer. And he was asked the question, what made the greatest difference in his post-cancer journey? The confidence gained from seeing positive results on the SOZO scan. For cancer survivors, scans are usually stressful and bring up lots of emotion. And certainly this guy had been through a lot, and that I can attest to that. But I look forward to having my SOZO scan to see how I'm doing in the gym from Kevin. So he went from doing very little exercise to 3 or 4 exercise sessions a week, resistance-based training. He wanted to get back to work. He's achieved that. So for me, it shows really quickly that even one small change in the right direction using body comp information can be so powerful for the patient. And I know I'm going to hand over to Maree now, and she has some pretty good data to show as well about some of the other parameters.
Thank you. And I think before we hand it off to Maree, that's such a powerful case study that shows how just one of the metrics available on body composition has significantly impacted a patient life. We have a couple more questions about reference ranges I wanted to see if you would answer before Maree begins. The first is, how is a healthy population determined? So you talked about these are based on healthy populations. How's that determined?
Yeah, so obviously the ones we're using have a large data set, you know, so we're trying to get as many specific age groups, you know, whether they're male, female, ethnicities, to really develop that healthy range. And then we're using that, you know, either a standard deviation recommendation, or we're using data from, as I said, the American College of Sports Medicine for fat mass. For skeletal muscle mass, we use a standard deviation as well, but that's derived for some other research papers. So I know on our website, Joanne, if people wanted to actually look at the specific reference papers that we're using to derive those reference ranges, they're all available on that site, or certainly reach out to your local ImpediMed person as well, because they can run through those. So ultimately, we're trying to find a reference range that suits, you know, the majority of the population, allows them to have a trend over time, which is really the most important factor, and deliver the right message to the patient.
Thank you. And we did get a question too about the age brackets. And I'll just say that the reference range document available in our Knowledge Center on ImpediMed.com does have the breakdown of ranges by age bracket and by male, female. And if you don't know how to contact your ImpediMed representative, you can visit ImpediMed.com, select contact, and we will get somebody in touch with you. So thank you very much. And Maree, would love to hand it off to you to start your case study.
Thank you. And I'd like to reiterate what Adam says. In the cancer population, we have those that want to get back to where they were prior to perhaps their cancer management. But we've got also the flip coin of those that have been doing no exercise, and it's a window of opportunity. So this is such a powerful way of assisting them. So this person, though, we're going completely to a different topic. So we're going to look at the Lipo Lymphedema obesity type of person who can walk through the door. And I'm sure we've all seen many of these clients. This particular person's 52 years old. Her initial consultation with me was in April 2016, so a little while ago. And she was at that time 197 kilos, so 434 pounds. And she was a huge anaesthetic risk for anything, really. She had a mixture of obesity, lipo lymphedema, and at the time, her main swelling was below her knees, and you can see that sort of area. So we decided to give her some wraps, which did help, but it's a Band-Aid because her biggest problem was her weight, and little did I know her also low muscle mass as well. She also had a great deal of pain that required a knee replacement. And if she didn't do something about her weight, she was going to end up in a wheelchair. And the orthopedic surgeon basically said, look, you really do need to address the weight. I cannot operate and before we look at this. So next slide. So how many times have we heard this before? The roller coaster of diet programs. She had no success, as most of the diet programs really don't consider the psychological issues as well. So she had a huge amount of issues from a psychological perspective. So she really needed a mind shift. And that really required a multidisciplinary team approach. She has a wonderful general practitioner. She has a wonderful psychologist, dietitian, myself, an exercise physiologist. But with someone with that amount of weight, it was going to be difficult. So she did go for the gastric sleeve surgery. Then she just didn't sit on that. She went through a strengthening program via Pilates, and her exercise physiologist assisted her there. To make change, it was both from a physical and a psychological perspective. She needed to get away from just looking at her weight. She needed to look at health, was her view. So next slide. So this is a busy slide, but I just want to show a few things. As you can see, back in 2015, she was at her highest weight, which was 197 kilos. And she started some meal replacements pre-surgery. Then she had her gastric sleeve surgery. And you can see when she has done some of her measurements, for instance, if we look at weight, which is the second column on the left, she went from 146 centimetres to now 83 centimetres. So that's a huge shift. And if we look all the way to the right in kilos, she went down to 76.2, which is a reduction of, 120.8 kilos, or that 266, pounds. So it is massive changes and life-changing. So let's have a look at the next slide. So where did the weight loss occur? I'm not going to spend a lot of time on this because we're really going to drill down. I'm quite excited about looking at mysozo.com and showing it live. But our measurements started in 2018 because that's when I got my hands on bilateral SOZO, which was very, very exciting because it meant that I could put anyone on the SOZO machine. And you can see basically the weight. Obviously, there was that reduction from 2018 to July this year. So that's not the biggest weight reduction because I didn't have that back then. And then we're looking at the skeletal mass. There was a little bit of drop, but the fat mass, have a look at that, minus 40.9, and the extracellular fluid, minus 4.1. So just hold on to that. There was a reduction in the total body water, which was a bit interesting. So we need to consider that as well. So next slide. So I might just get you just to run through these next photos that I want to show you, because that's the impact of before and after. And you can just imagine the amount that she can do now. So she doesn't need a knee replacement. She's really, back on track. She can do everything she wants to do, which is fantastic. And 61% reduction in her body weight is enormous for everything, not just her swelling. Her swelling her legs were actually the least of her problems. It was the rest of her body, staying healthy was important. So the next slide. So it's always nice, like Adam did, to hear from our clients what it means to them. You know, it's exciting for me, but what does it mean for them? So having regular SOZO tests helps provide me with a comprehensive, accurate, and more in-depth gauge of progress, both in terms of the weight loss, the muscle buildup, the fat muscle ratio, but also in terms of overall health, improvements in terms of the fluid retention, lymphedema in my legs. And it's interesting because when I spoke to her general practitioner, I reached out to her, sometimes she would never actually weigh her. And I said, oh, why was that? Because it was a negative effect. So in fact, with some of my larger clients, I know we need to get weight for SOZO, but I get them not to look at the scale. I said, I'm not interested in that. I'm just utilizing this to get our measurement. And then I hone in on muscle mass because that's the positive. You know, these people get so stuck on the weight that we really do need to get them into a positive frame of mind. So do we want to move now to looking live at the data?
And while you're pulling that up, Adam, we have a question about the max weight on SOZO. So the standing max weight is 375 pounds, but you can also use it in the sitting position as well for patients that weigh more than 375 pounds.
That's a good question, actually. So here we go. So we're into the into the data live, so we can play around with this a bit more. So one of the things I did when I chatted with Adam, thank you, Adam, for helping me with this client as well, is I said, what's going on with the total body water? Why have we lost from baseline? I was a little nervous about that. Adam, do you want to comment on what we discussed?
Yeah, absolutely. Yeah, it was a really interesting case study. And I think because ultimately when I look at body composition, I'm trying to maintain that level of total body water, because that's an idea of, you know, the fluid status of my patients. And I mentioned myself before, like nearly 3.5 litres of fluid down from, you know, moving from, you know, the winter in Australia to you know, 40 degrees, 100 degrees Fahrenheit in Texas. So ultimately that's critical. But when we delved a little bit deeper with this particular patient, it's really interesting where that overall fluid loss was. So if you can look here, we work through the total body water. We have on the last measurement, which was only just recently, Maree, a couple of weeks or so ago, you know, a 36.2 litre total body water and a percentage weight 46.5. And the litre change does look significant, minus 5.9. Interestingly though, where is that loss? So when I said from the start, you know, I need to know how much fluid my patients have, but also where that fluid is, you know, and in our body composition language, how much is inside the cell, intracellular fluid, how much is outside the cell. And ultimately, I think, Maree, you can see a minus 4.1 reduction in extracellular fluid. Yes, there's a little bit of intracellular fluid loss, but remember, this patient has lost kilos and kilos of body fat and a significant change in weight. So it's not unrealistic to expect that there'll be little changes in some of these key parameters. But I thought it's an interesting one where you've kind of said, hey, that's a significant drop, but it's actually a drop in the right area. Is that kind of what you...
Yes, I agree.
Yeah.
And unless you look at that, then you start to get worried about it. So I think it's really, if we look at those parameters, and they're the parameters I do start with. So let's have a look at, you know, total body.
Yeah, so, and as I said, you know, in my presentation, one of the great things now with version 4 is you can look at the history. So 1 measurement doesn't tell me a lot, 2 gives me a little bit more information, 3 gets a trend. But you can see here when we look at litres of total body water, as this patient is losing significant amounts of weight, there is a pretty strong trend downwards. Now, not huge amounts of litres, you know, that 4 or 5 litres, but because they've lost so much body weight, look what happens when we look at percentage of weight. So it's actually a positive increase when we're looking at overall percentage of weight for total body water. So it's an example of which data do I want to look at clinically. So Maree needs to look at that. But also then Maree, as the clinician or the healthcare professionals that are listening, you need to figure out what information is going to be most valuable for me to deliver to the patient to get the outcome I want. So I hope that helps.
So the next thing we tend to look at is the extracellular fluid, obviously, and the intracellular fluid. And we try to get that, you know, I was always taught by Adam, the 60-40, and that's in the prime person, I think. But it's looking at that over time. It's that, you know, that healthy range. So Adam, do you want to just have a little show of where we've moved from with that? Because I think that's really interesting.
Yeah, definitely. So we looked at a couple of things with this particular patient. So if I go back to the very first measurement, and while that's generating, Maree's right. Ultimately, if we were young, fit, healthy, active, I say 20-year-olds, a 60-40 split is kind of the ultimate. So 60% of that fluid inside the cell and 40% outside the cell. As we age and there's obviously disease that comes in, ultimately that ratio does change. And you can look at this patient's ratio from the very first scan we have, 2018. So we have a ratio that's very different to what it is today. So extracellular fluid, 47.8 as a percentage, and intracellular fluid, 52.2. But if I then quickly go to the last measurement, and also why that changes over, you can see also there she was in a 3 standard deviation range. If we think of that reference ranges that we talked about before, she's one of those outliers at that typical kind of reference range. So still within where the 99.7% of the population would sit, but she's in a -3 standard deviation with that ratio between intracellular fluid and extracellular fluid. But now look at the change in the extracellular fluid, intracellular fluid ratio. So that's kind of matching up with, we've lost 4 liters or so extracellular fluid. That ratio now has gone from -3 standard deviations back into that -1 to +1 standard deviation, and actually very close to the mean of the population for someone her age and being female. So that's to me a fantastic change and a positive change that Maree can then deliver to this particular patient. So she's right on the edge of that 55 to 60% range for intracellular fluid and 40 to 45%. So that in itself is, a great way to really look at the information. So I thought that was worth sharing as well, Maree.
And it's really telling them they're much more healthier. She's, look at her, she's, it makes sense. She's lost all that weight. But if we look down at the Hydex, because that's something I sort of play around with a little bit. So my idea of using the Hydex is just to make sure they're monitoring the fluid, because obviously we're measuring everything's around fluid. So if it's, if they've got very low, I suppose it's trend over time, as you say, in regards to that. But are we getting an accurate reading sometimes? Because if it's going up and down, are we getting an accurate reading for our muscle mass, for instance, if we've all of a sudden, have less fluid on board and we're much lower? What would you say about that, Adam?
Yeah, 100% agree. And also you can see here, again, we've set a baseline for this particular patient. So this was the baseline measurement. So change from baseline from the original, there's always little fluctuations. Yeah. But ultimately the change from that baseline, 14.3 points. So she, again, would have been down in this kind of reference range where that baseline is, and she's moving in the positive direction. So, Hydex, you're spot on. It's a great way to determine, is my patient in the normal typical fluid status from the previous measurement? And if they're not, that's a great conversation to have. And, there's lots of instances where we're educating patients in particular on how to use this technology. We might have a conversation around fluid for the first measurement. 3 months' time, they come back for their second measurement and they're carrying a water bottle. They're saying, hey, I listened to the fact that I need to improve my fluid. So, it's a great way to kind of introduce it, but that's really what Hydex is for. And you can see, again, for this patient, I want them heading into the more hydrated section. Now, certainly in the US, it's slightly used differently to how Maree can use it, because it's really intended for healthy patients. But it still gives us the trend over time that we're looking for from a fluid perspective. So we've used total body water, intracellular fluid, extracellular fluid, and Hydex to really go through that.
Maree,
go for it.
You guys, you had a great conversation about intracellular, extracellular fluid and the relative ratio. Can you give the audience a little bit of kind of conceptually, where in the body does intracellular fluid reside? Where in the body does extracellular fluid reside? And how should they think about how that relates to their patient's health?
Adam, you go for that, because I've got a question for you then.
I was going to say, thank you. I was going to hand it over to you, but okay, I'll put some comments down and you can follow up. So
yeah, sure.
I mean, generally intracellular fluid, and I always say intracellular fluid's the kind of good stuff we want. So exactly what it is inside the cell. And if you think about muscle tissue, and we'll get to that in a minute. So muscle is majority made up of fluid, and that's that intracellular fluid perspective. So as we're building muscle mass, you should certainly see some increases in intracellular fluid. That's where a very healthy cell will have a higher percentage of intracellular fluid than extracellular fluid. Now I'm going to hand over to you, Maree, because I know you're the lymphedema expert and know everything about extracellular fluid. So tell us about extracellular fluid.
So that's where we're monitoring in regards to our lymphatic system. And so obviously if it's going up, we need to obviously look at our management strategies in regards to that. So we are often reflecting that with the LDEX, and that's where we, fine tune that for our lymphedema world with that. So that's a different area, I suppose, as well. But one thing that I have a question, which I haven't asked you before, Adam. So say someone walks through the door. I'm looking at extracellular, intracellular, completely compared to the last time. So I've done the whole measurements. Do I bother going on to look at skeletal muscle mass? Because
yeah, sorry, Maree, you just dropped out, so I didn't actually hear that question. I'm not sure if it's my end or your end, so you may just need to repeat that. Or Joanne, if you heard it, please jump in.
Yeah, it cut out from mine as well, but I think what she was getting at is if she sees a change in ICF, do you really then even need to bother looking at skeletal muscle mass? But maybe you can talk about that in the next, as you get into skeletal muscle mass, how you relate it back to ICF, to intracellular fluid.
Yeah, absolutely. Yep. Okay. So yeah, I mean, if we think about skeletal muscle mass, Maree, as I said, a big part of that skeletal muscle mass, or muscle mass in general, is intracellular fluid. I always say muscle is the good stuff, the stuff we want to keep. So more often than not, if we're seeing an increase in skeletal muscle mass, potentially you'll also see an increase in that intracellular fluid ratio. So they kind of work hand in hand. If you're looking at intracellular fluid compared to extracellular fluid, and again, you're seeing improvements in intracellular fluid ratios as a percentage, it could be that obviously there's a reduction in extracellular fluid, or there actually has been some muscle that has been built, and that generally will get picked up with that skeletal muscle mass number. So Maree, I'm really keen to ask you and talk to you about the importance that you place on skeletal muscle mass for this particular case study, what it means to the patient, and also what sort of information you look at on this particular parameter.
Sure. So can you hear me okay now? Is that better? Am I?
Much better. Thanks.
Okay. So I'm not sure what happened there, internet. So with this particular person, I think it's a fairly typical of anyone that's morbidly obese or with issues, with obesity, is I really try to move away from fat mass, just concentrate, because that's what they're all about, isn't it? It's all about the fat, I'm overweight. So what can we positively, look at? And the skeletal muscle mass, and sometimes, funny enough, if they've got a low skeletal mass, it's helpful because it actually gives them a reason, that perhaps that's something they can work on. It's not just diet. It's not just what they're putting in their mouth that can actually have an impact on the fat mass. So, for this particular person, Monique, it really was when she was losing all that weight to maintain it. And that was important because sometimes when they lose this sort of volume of weight, their muscle mass can go off at the same time. So I think she's done an excellent job of doing that. And she was outside the radar, obviously, with the fat mass. So for her, we're building up the strength. And if you can we have a look at the skeletal muscle mass little profile? Because what we've found, and, we've had a bit of so this is nice, see how you can just click in there and have a little look. So there has been a drop. We've had a chat about this from that sort of October of last year to now. Remember, we've had COVID, so she hasn't been able to, and we've had a number of lockdowns here in Australia as well, so it has been a bit more tricky. So she perhaps hasn't been exercising from a strength training as much as she possibly has, but also hasn't maybe increased it as much, so really loaded it as much as she normally would. The other thing that I think is a positive thing to talk about, and I'm not a dietitian, but I did have the discussion, is how much protein intake she's got. So we need the protein, it's a healthy stuff, rather than talk about, what sort of fat intake have you got, that's negative. Have a look at the protein. And she, admitted that she probably could improve that. This woman's all over her diet. She's been there, done that. She's been living with this for years. So she understands what she should be doing. But really now we're trying to ramp it up, and we talk about looking at change in 3-month intervals. So we've just discussed about, she's going back to exercise physiologist as well to look at some more strength training, look at her protein intake and all that area. And we're going to try and give her a target of 3 months to see, can we start pushing that, that measurement up in regards to her muscle mass.
Mm-hmm. Yeah, and it's interesting. I mean, I listened to what you're saying there, and I think this patient, we've got to remember, had brilliant care. So obviously she's got your expertise, but also, she's been in contact with exercise physiologists, the PT, the rehab side. So when I look at this, yes, it's around about 1 kilo change of skeletal muscle mass, but remember how much body weight this particular patient has lost. It's actually a brilliant result, because I think if we took away, the exercise physiologist component and maybe some of the nutrition conversations and all the help from the healthcare professionals she had, I doubt whether, we would see only a 1 kilo, really, a couple of pound change in skeletal muscle mass. So I think it shows also that we've managed to maintain this skeletal muscle mass using a team of healthcare professionals, not just Maree O'Connor, but an exercise physiologist and nutrition and all of the guys that are really trying to change the person's life and change it for the better. But what we discovered, Maree, when we were talking the other night about this is, yes, there's a 1 kilo change, but when we look at percentage of weight, look at what happens here. So we know that as she's losing significant amounts of body fat, it's not muscle. As a percentage of weight, we're actually seeing an increase in skeletal muscle mass percentage. And I think we talked about, well, how do we deliver this message to the patient? Because we want to make sure we're giving the right information, we're motivating. But for me, this is how I would look at, in the first instance at least, and say, hey, look what we've achieved from August 2018 to July 2021. And I know typical, we're human beings, patients are going, yeah, but I've lost 1 kilo of muscle mass. And, I would say, look at the percentage change. It's a much healthier overall body composition that you have from the program that you've gone through. And you're 100% spot on. I think we talked about the fact that there's been a little bit of a drop off the last 2 or 3 months. So COVID's part of that. And I think also she stopped doing some resistance-based exercise, went to water aerobics. So if those things hadn't been in place, do we still get the same trend that we're seeing here as well? So that's where the power is in, the data. Once you understand the information, so we need to look at fluid, we need to look at muscle, we need to look at body fat, then we can really pull out as healthcare professionals exactly what we need to do. Ultimately, from my side, how do I deliver that message to the patient that she's going to keep coming back? She wants to refer that information to other healthcare professionals because she wants the best possible outcome for herself. So really powerful, and I appreciate you sharing that. So,
and Adam, can I also say that we don't worry about her lymphedema anymore because she's lost all that weight. So in fact, her obesity really was impacting on inguinal nodes and causing, some of that swelling down below. So you can just imagine if you're reducing that amount, you're carrying a house on top, then it's positive. So she doesn't need to wear a compression garment, which is excellent.
Brilliant.
Now, Adam, if you wouldn't mind going back to that skeletal muscle mass trend, we have a couple of questions here that are related. So one of the questions for you, Maree, is when you're working with a patient on body composition outputs, how quickly can you expect to see change occur, noticeable change that you can pick up in SOZO, and how frequently do you like to test?
Yeah, and that's a really good question. And it's going to, I hate to say it, depend on the individual and where we're heading. So if it's someone that really wants to get back into that rehabilitation phase, compared to someone who was looking at, in the cancer world, so you're going through their cancer management, that I often will look for maintenance, not the drop off in the muscle mass. So if we can maintain, it's great. So that ties into often when I'm measuring the LDEX anyway. So it's that whole surveillance program. So you're looking at every 3 months, and pretty much body composition falls into that as well. It's no point in coming back every week. You need a period of time to build up strength. So that 3 month, I think, is important. And it's trend. Even if it's a little bit high, it doesn't matter. Do you know what I mean? It's trend in the right directions. And I think what Adam says, you're going to have the bumps, but we're all going to have the bumps in life. But it's that trend. So every 3 months, that's my.
So 2 questions based on that answer, and both are generated by Q&A from our audience. So you talked about cancer patients. Adam presented the cancer patient case study at the beginning. In the case of that patient, the question is that 2 kilograms of skeletal muscle mass is a noticeable gain. Are there measurement errors established for men with prostate cancer? Is it possible that a 2 kilogram change is due to methodological error and interpretation? Does interpretation depend on this? So does your interpretation of body composition outputs differ based on who the patient who's in front of you, or the person who's in front of you?
Adam can add to this as well, but not in regards to muscle mass. I take it as it is, I think. So obviously I'm taking in light of what other treatment they're having to know if there's going to be issues that, that might reduce it. What do you say, Adam?
Yeah, look, I think my answer to that question is what we said from the start. We're not just isolating skeletal muscle mass. We're looking at fluid, we're looking at muscle and fat. So once I've got an overall picture of those, I always talk about the 5 key parameters, where that fluid is, how much they have, and then, muscle and fat. It gives me a lot more confidence then to look at that number. But again, it's really trend over time. And yes, it's a small change. And I kind of, in some respects, agree with the question, at what point is that such a small change? But ultimately, that changed the life of that patient. So as Maree's saying, I'm going to take that and use that to my advantage. And yes, there'll be little variations. We know we correlate really well, with our dilution techniques. We've got, some really good standards that we're utilizing. So we know also that, the SOZO device uses 256 different frequencies. We have a lot of data to really support the measurements that are coming from the device. So that gives the confidence to certainly Maree and other clinicians to really use that information. But isolation, correct, can be a little bit of a dangerous game. But when we look at it as a whole, and we're trying to determine what the best outcome is for that patient, then I think, it's a great number to share.
So Adam, if you had another measurement of that upwards trend, then you would feeling more confident.
Correct. Yeah. As I said, a one-off measurement for body composition really doesn't give me a lot of information. A second and a third, and then, multiple, then I can start to develop some trends. And we're a living being. There's always changes in fluid, muscle, fat, but ultimately it's that trend I'm looking for. And, I think the 3-month timeline is a significant enough timeline to be able to see if there's been any change with skeletal muscle mass. When we're really dialing in on nutrition, and if there's any nutritionists got to listen to this, if we're dialing in on nutrition and everything is being prescribed from, say, an exercise physiologist, a therapist, a PT, so all the dots are kind of lining up, I would say even like a monthly measurement becomes really useful to see if there's any trends occurring from, say, today, 4 weeks, 8 weeks, 12 weeks. But ultimately, that first measurement to the 12-week or the 3-month is really the critical number. What having a look at, say, 4 weeks and 8 weeks does is just to pick up on anything that's trending potentially that needs to be looked at. Is there fluid dropping off? Because we've just increased the amount of training that they're doing. They haven't done any exercise for 20 years, and now we're getting them to do 3 to 4 resistance-based sessions a week. So that can have an impact on the overall body composition. They're exercising more, so they're burning more calories, because I know, and we'll look at, metabolic rate as well. But, are we then giving them enough food to maintain that muscle mass as we're introducing this exercise? So that's where those interim points are really powerful. So, if you're looking at using body composition within your clinics, within your hospitals, the ability to really build a program around body composition is really probably the way to go, as opposed to a one-off measurement. So, with patients, we can say, hey, we need some data. We're going to get a measurement today, 4 weeks, 8 weeks, 12 weeks. Ultimately, the change we're looking for and the trend is over that 3-month period. But we can then make some little adjustments. And I think, Maree, I've shared my data. I did a 12-week program just before Christmas from October to December when I was in Australia. And I did weekly measurements, and I was surprised how precise the changes in body composition were. Ultimately, I had some goals to achieve, and it allowed me to really make any changes. And one of the things I did see was a drop off in skeletal muscle mass. So instantly I added another meal of protein, essentially. And then I could see that drop off had leveled off, and it started to increase as well. So I hope that helps, the audience to kind of have a bit more understanding.
And it also, I suppose, with this particular person, we noticed there was a trend down, so we need to intervene. So it's not just one episode. There is a trend going down, so that's important.
So where would you like to go now, Maree?
Yeah, we've got 7 minutes left.
Oh, okay.
Would you guys like to take some more questions from the audience, or would you guys is there anything else you were hoping to cover in the next 7 minutes?
I think really, because we've covered the skeletal muscle mass, it really goes hand in hand if the fat mass has dropped off. We're still in a high range, but we've gone from off the radar, haven't we, down to that. Was there anything else about fat mass that you wanted to look at?
Oh, the fat mass history, I think is just, again, if it's my patient, I'll do this really quickly. I think it's a great thing to still focus on, because I know.
Yeah, I definitely always do.
She's conscious of fat mass, but to me, this is an unbelievable result, like 70 kilos. So, and Joanne, you can do the calculation to pounds, 150 pounds or something like that, but, down to around about 30. So that's a massive change, and that needs to be applauded in terms of what we're trying to achieve for this particular patient. So there's no issue at all with what's happening.
And also looking at that too, is you're looking at just a little bump at the bottom. Like it's not a massive increase in fat mass. So we can't hone too much on that.
Yep.
As such.
Yeah, and we've already talked about, okay, we've seen a little bit of a drop off in skeletal muscle mass for these last 2 or 3 parameters. So that's where Maree can go and work with her patient to talk about the resistance exercise, and potentially I think you'll see there may be a trend back downwards in that body fat. So I just want to highlight that. And I think the other parameter, certainly, Maree, that you just wanted to make a comment on before we take some questions, were body mass index and phase angle.
So body mass index I never use. I can't stand it. I don't tells us what, anything, really doesn't tell us anything. So I don't even look at it. So that's one thing. And I wish the research had all this other wonderful information about, fat mass and skeletal muscle mass. Phase angle is useful, and I'd like to show this particular one, because my understanding of phase angle is about the health of the cell. And in our cancer population, when I take an initial measurement, and sometimes if they're on chemo, it's very low, 1.82, I don't comment on it. But as we track them over time, that improves, obviously, then I do comment and say, look, how much better you're getting. But if we have a look at this particular Monique's one,
so you can see obviously there's always little fluctuations, and you remember how much change is going on inside this particular patient.
Yes.
But ultimately there's just that little nice trend upwards, and that's, again, it's a great thing. Now, if phase angle, my explanation, I think, and trying to simplify it again for the patient, if the phase angle is improving, things like intracellular fluid and muscle mass, generally the good things should be improving as well, because the quality of the muscle and quality of the this at the cellular level is improving, and that's exactly what should happen when we look at this particular patient. So I'm glad that you kind of brought that phase angle into the discussion. So it's really useful. Trend over time, no different to any of the other parameters. But look at the trend upwards. It's only a small change, but that's, again, powerful for a patient.
And she had a couple of surgical interventions, which may have also dropped her phase angle as well in regards to her healthiness. So they're the areas I literally, they're the parameters I look at.
Great.
When I chat to clients. Awesome. Joanne, questions?
Yes, thank you. We have a lot of questions. So there's a couple really interesting questions as far as how do you talk to your patients. So one is, how do you talk to your patients about hydration and why is it important? And another one is, how do you tell your patient why SOZO is different from the scan they can get at their local gym?
Okay, so maybe I'll take the first one and then you can take the gym. So when I have someone that walks in, and I think I was thinking about this on reflection before I came to this session, is well, why don't I just put someone on SOZO and do my LDEX? I'm a lymphedema practitioner and just leave it at that. But it's a bit like saying to someone, here's a compression garment, but leave it in your drawer. Do you know what I mean? I need to use all the parameters. And I think now it gives us an opportunity to open up that discussion of, and actually, you know, before I had to weigh them and that was it. I didn't know what was going under the surface of the skin. But then it does bring us up to that everything involves fluid. So we really need to make sure that fluid is on for the health of the cells, for the health of the tissues, for the health of them. So I start with that sort of approach. And I do mention that they need to drink before they come to a consultation as well. So that's the fluid. It's based on the fluid, because you can't go into too much technical detail. So we're looking, you know, our body is fluid as such, and then break it down to talking just like we've done. You know, we've got some fluid outside the cells and we've got the others that, you know, inside the cells, and moving on from there. So that's how I sort of talk about it. But in regards to the gym versus this, it's the technology, isn't it, Adam?
Good, Maree. Yeah, it is. I mean, ultimately, there's lots of different technologies out there. You know, some we would class as, say, a single frequency device. You know, so it uses only one frequency to sweep across the body. It's got to apply a whole range of algorithms to really come up with that end result. So it's making lots of assumptions. And even in the early days, ImpediMed certainly had a single frequency device, but we've come a long way. And then there's really multi-frequency devices. So what they're, you know, some between 2 to say 6 frequencies quite often. Again, it gives a little bit more information, but still not 256 frequencies that we're using. So we have thousands of data points to really determine our extracellular fluid level. That's why we can use it for things like LDEX and also our intracellular fluid total body water. It's all based around fluid. You know, once we know the fluid, we can calculate things like muscle mass and fat mass. So you need the accuracy around the fluid, and we can show a fluid change of 36 mils, you know, 2.4 tablespoons. So we know we're really precise, and that's how our technology is actually developed. Most of the other technology that you see in a gym, reasonable technologies, but they just don't have the same amount of frequency and information to be able to get the data that we can. So I hope that answers the question.
Before you ask another question, the one area that we haven't looked at is segmental. Can we just quickly look at the segmental, maybe on the legs, just to highlight that? So if we look at the legs and we look at the skeletal muscle mass, they're pretty even from side to side. But how do I use that with other clients is I tend to say it's a person that's had hip replacement, a past history sometimes of a hip replacement, you're going to see differences from side to side, or a breast cancer person who may not be using that arm as much. So it highlights, I think it drills it down to what's going on in that particular limb, which is what we've been asking for a long, long time. I'm only starting to play with this a bit more, but sometimes even with my primaries, I've had one recently that's really weird. Her one leg, you know, skeletal mass is quite different to the other side. So it allows us to be specific. So not just look at the big picture, to drill down into the areas that are required. Adam, do you want to add anything to that?
Yeah, I mean, we've sort of run out of time. Just really quickly, I know we will do a webinar specifically on segmental, so please watch out for that and the promotion. But I mean, there's really 2 or 3 key things with segmental, no different to the conversation we've had. You know, we're looking at fluid, we're looking at muscle, and we're looking at phase angle. And if you look at some of the current measurements to change from baseline, again, we're seeing total body water in the left leg has been reduced, extracellular fluids come down. So we've already talked about that. But interestingly, the quality of the overall leg from a phase angle perspective is up one whole point there as well. So yes, there's been little changes in muscle, but it gives Maree as the clinician just a little bit more information to go to, and then deliver that to the patient, depending on what we need to look at. And I think early on, you can see the right leg, I don't think it had as many problems, Maree. Yeah, so the phase angle, as an example, hasn't really changed, but there's been a big increase in the phase angle on the left leg. So we know the quality of that leg in terms of the muscle and the fluid and the health of the cells has certainly improved with the treatment and the change in the programs that have been put in place. So watch this space for the segmental. Reach out to the ImpediMed team. We're learning as well. There's some fantastic little case studies that we've already seen. So if you haven't got access to it, reach out, and we're more than happy to assist.
And my other suggestion is, if you have got the SOZO and you have got this version, as well is to actually reach out to your ImpediMed team to help you with your clients. Do you know what I mean? To talk you through some, because, you know, we've covered quite a lot in this one session, but it makes a lot more sense if it's one of your clients, and then you can move straight away and make implementations to your management.
Thank you, Maree. Thank you, Adam. This has been
Pleasure.
just a really wonderful session. We went, you know, really deep into these body comp case studies, and I hope that the audience got more insight into how they can use it in their own practice. We do have a number of questions that we didn't get a chance to answer. We will follow up with you individually to get you responses to your questions in the next few days. If you have an interest in participating in future webinars, please watch our e-blast, watch our social. You can visit our events page on impedimed.com and pre-register for upcoming webinars. And we will do a webinar in Segmental early next year as well. So, and replays again available at the ImpediMed Oncology YouTube channel. So thank you, Adam. Thank you, Maree. Really a pleasure to have you here talking with our audience. And thanks, everyone.
Thank you.
Thanks, guys. Take care.
See ya.
Bye.
Bye.